to say, I'm so glad to have so many people with us, and some of our friends from other towns that that have been involved with us for so long. Ed and Janine J. Chardon, who Ed was the architect who helped me design this space, and Janine was my chair for a very long time, so very glad to have you with us. And certainly we wouldn't have this space if it hadn't been for Ed's help. But it's so good to be able to welcome Dr. Gail and Hope Schwartz. And Dr. Gail is an associate neurologist at Brigham and Women's Hospital, study physician and investigator with the Center for Alzheimer's Research and Treatment, also known as CART. And is an instructor of neurology at Harvard Medical. And Hope is a program coordinator at the Center for Brain and Mind Medicine at Brigham and Women's. So really very, very glad. And Carolyn is here as outreach for them. But very glad to be able to welcome you out here. I know that's quite a trip for you to come out. And thank you so much for your willingness to be here and present this very important information. And I'm so pleased to have so many of you with us. This is our keynote speaker for our Health Education Week, which has been a fabulous week with a real focus on health education. We've had some fabulous discussions and presentations on fall prevention, on medicine management, on nutrition as well as along with our fitness programs that are ongoing. So this is a great way to wrap up our week, and we really appreciate your time.
Sure.
So I'm going to turn it right to Dr. Gail so that we can give him plenty of time to talk, and then they can take questions. You know, I'm sure we all have things that we'd like to be able to talk with you about.
Sure.
Just to let you all know, we do have a men's room and a women's room labeled as boys and girls right across the hall on the left. And I thought, you know, it was really kind of charming to leave those pieces in place from the school, so we've really appreciated that. And I also have coffee and both decaf and regular, and tea and water and cookies, so anything that you need, just please let me know. And I'm going to turn right to you.
Sure.
And thank you again.
Sure. All right. Hello, everybody.
Hi.
How's everybody doing?
Good.
Good. So it's a pleasure to be here. We have not been to Georgetown before. It's a lovely town. On the way in, we'll spend some time on our way out as well. Couple starting questions. Who has done Tai Chi before here? Raise your hand. That's great. That's bigger. That's larger numbers than I've seen before. Who has done yoga before? Excellent. So I understand that there's yoga and Tai Chi that's going on here, which is fantastic. Who took part in other health activities as part of this week that we just heard about? Anybody else?
As part of what?
As part of, this was a health promotion week, I guess, here, where there were a lot of particular health activities. Did anyone do other activities? That's great. Good, good. I see some hands, that's great. So what we'll do, Hope and I, is we're gonna talk to you about brain health from the perspective of neurology. So there's the disease aspect of it, and there's also the normal aging and brain health aspect, and both are tied, as you'll see. So I'm going to give a little bit of an introduction, and I hope everyone can hear me. Just shout out if you can. I'll give a little bit of an introduction about who we are and the center that we work in and what kind of work we do there. And then I'll turn it over to Hope, who's going to talk about some of the background for the science behind brain health recommendations, why exercise and healthy eating and social and mental stimulation, why those things are important. And then I will, how will we do this? And then towards the end, I'll come back and talk a little bit about sleep and something called cognitive reserve and medications and a couple other things. And we want to leave plenty of time for questions.
Would it help if I dim the lights?
Maybe a little bit, sure, that would be great.
And then I can bring it back.
So I'm gonna run through these.
How's that?
Yeah, that's better for me too. That's great.
You could do more.
No, I think that's good. It's easier to look out when there's less light.
Precise.
So I'm gonna run through a little bit. So who are we and what is CART and CBMM? We're gonna talk about, as I said, the background. So what is normal aging versus what we call dementia, and a little bit about past and future studies of what is going on right now with clinical trials and in this field. And then we're going to spend a bulk of time talking about brain healthy behaviors which is a lot of stuff that you kind of know about and you have in the back of your mind, but there are some particular recommendations that large studies have shown can be particularly beneficial. So we're going to make sure to highlight those. So we work at the Center for Brain Mind Medicine. So this is a clinic or a center within Brigham and Women's Hospital. And the folks, the specialties that in medicine that take care of or evaluate patients who have thinking or memory or behavior difficulties are from a bunch of different fields. They include someone like myself who's a neurologist. I'm a neurologist by training, but my subspecialty in neurology is cognitive and behavioral neurology, which is additional training beyond what you get just in basic neurology. The other fields of neurology are things like epilepsy and stroke and neuro-oncology, brain tumors and things like that. So there is a subspecialty in both clinical care and in research that is particular to dementia and also to any other cognitive and behavioral disorders like attention deficit disorder, for example, is something that falls in this category. And then in that group of providers are also neuropsychologists. So these are folks who are particularly trained to interpret and help understand performance on memory testing, on thinking and writing testing that you would have done as part of an evaluation. So those are folks that are psychologists by training, but then have an additional specialty in interpreting cognitive tests. Then there are neuropsychiatrists that we work with, who are psychiatrists typically by training, but have additional expertise in helping patients who might have a neurological problem, let's say MS or Alzheimer's disease, but are suffering from significant psychiatric problems like depression or agitation or anxiety or things like that. And the mission of the center is to provide really what I think is a multidisciplinary approach. So if you were to see someone in our center, you might get evaluated by a neurologist first, but then I forgot to mention one other specialty which is extremely important, which is social work. So we have social workers in our group who, if you connected to me and were started to be treated for let's say Alzheimer's disease, we have a whole support group that's in social work that would help to connect you to services, to help caregivers with behavioral strategies, to help care for someone who has dementia. So anyway, that's the general framework from which where we come from. And the other mission of our center is research, because as many of you know, in these diseases, in dementias, in what we call neurodegenerative diseases, there aren't any effective medications yet that can change the course of decline or that can cure the disease. So that's one avenue of research, which is to try to find novel drugs and novel therapeutic strategies in general to treat Alzheimer's. The other part of the mission is early detection of cognitive changes and other biological changes that you can detect sometimes before you can actually detect the changes of something like Alzheimer's disease. So those are the two avenues. And I will put these two slides up again at the end. And before I forget to, we have a sign-up board over here for learning more about either clinical care or about research opportunities, so we can come back to that too. Okay, so with that, I'm going to turn it over to Hope, who's going to talk about cognitive aging, and I will be back.
Awesome. Can everyone hear me okay? Yes. Okay. Let me know if you can. I'm losing my voice a little bit, but I'm going to do my best. So as Dr. Gale said, my name is Hope Schwartz. I'm the program manager for non-pharmacological interventions for dementia in the Center for Brain Mind Medicine in the clinic where we both work. And what I mostly focus on in my work is how to get our patients to do the things that we know can help them with their memory and their thinking. And these are things that you can incorporate in your day-to-day life, like exercise and diet and certain things with medication and sleep that we'll go into detail about. And so what we want to do in this presentation is to bring all of these recommendations to you, tell you what we know, tell you a little bit about some of the background of the research studies that kind of got us to this point, how we know what we know, and then definitely just open it up for you guys to ask questions about any of these things you might be more curious about. We're going to go through, there's a lot of information here. I'm going to go through it pretty quickly because I want to get to your questions. But definitely, keep questions back of mind so we can come back if there's something you want to hear more about. So first, to start out, I want to give a little bit of background about cognitive aging and what we mean when we talk about words like mild cognitive impairment or dementia. And so this graph, I think, is particularly useful to think about. So this is a graph that shows cognitive function on the y-axis and age on the x-axis. And I want you to first just take a look at this purple arrow, this dotted line here. This is our normal aging curve. And so what you can see here is that, unfortunately, for basically almost everyone in the population, as you age, as you get older, your cognitive function is going to go down a little bit. Not too much, but you can see that it's, a little bit lower here in later life than it might have been in middle age or as a younger person. And that's not a problem. That's a normal part of the aging process. But we also have, what we would consider non-normal aging, and there are a lot of causes, potential different causes for that. The most common you probably have heard of is Alzheimer's disease. And this presents with a slope that is a little bit different and a little bit more troublesome. And so, you can see that as you're aging, your cognitive function is going down really quite a bit, to the point where when you get around here in what we call dementia, you really would be unable to kind of take care of your day-to-day activities. And so we like to think about this as kind of a continuum, a spectrum, starting with what we call preclinical or subjective cognitive decline. So people who fall into that category are people who come into the clinic to get evaluated, and they might say to their neurologist or their neuropsychologist, I am having more problems with memory than I used to, or, yeah.
I'm just wondering, are there an age sort of cycle when these things start occurring and when you can expect them to get worse, roughly?
Yeah, that's a good question. Do you have a thought on that?
Yeah, I can just step in.
Yeah.
So every decade past 30, let's say, there is an expected decline on normal aging, things like multitasking and attention and things like that. The most common age for the onset of dementia is late 60s or mid 70s. Okay, so that means that the initial symptoms of what is 85% of all late life dementia is Alzheimer's disease, which means there's some that's not, which we'll get to. But that's a rough estimate. The difficulty, of course, is that there are people who have, say, the beginning of age-related cognitive decline, what seems to be that's the case in their late 60s, but they're harboring the early changes in the brain of what we know to be Alzheimer's disease. So a lot of research focuses on differentiating that decline from normal aging versus what's the beginning of like an incipient disease. But it's hard to commit to ages, because as the curve shows, there is normal decline, and someone's curve, this is an estimate, could very easily be in the middle of these two, and they could not show the changes in the brain microscopically of something like Alzheimer's, but yet they're a little bit different than normal aging. So this is all areas of ongoing research. So we'll come back to those things.
Yeah, so we can come back and we can come back to other questions about everything we're presenting. So subjective cognitive decline is sort of your own subjective experience of your memory isn't what it used to be, you're not thinking as fast, you're having a hard time multitasking. But when you actually come into clinic and you sit down and you go through some testing with a neuropsychologist, we would see that you are normal, fall within a normal range compared to other people who are your age and who have your same educational background. And so it's important that people who are in this SCD group, they can stay on the normal aging curve, and a lot of them do. But a lot of them, or many of them, may also continue to decline into MCI or dementia. And so we know that SCD is a risk factor for dementia. It doesn't necessarily mean that you will develop it, but it means that you have a higher risk of developing it later in life.
What does MCI stand for? I don't see it.
Yep, so I'm going to go through that in the next slide.
Okay.
Yeah. So the next kind of topic or vocabulary I want to give you is MCI, which is something we talk a lot about in our clinic. And these are people for whom they have both the subjective experience of cognitive decline and also on testing have some evidence that their memory or their thinking is a little bit slower or a little bit worse than it should be based on just their age and their education. And many people, again, similar to FCD, you know, some people will kind of stay in this MCI group for many years, and others may progress into dementia. So MCI is you know, a common reason that people will come seek care in a clinic like the Center for Brain Mind Medicine where we work. And then lastly, the way that we differentiate dementia. So people with dementia also have more problems with thinking and memory than normal people who are their age. But the difference we like to think about between MCI and dementia is that once people have dementia, they're no longer able to go about their day-to-day activities independently. So they may not be able to work anymore, they may not be able to manage their finances, to grocery shop, and so that's really what we would consider to be, have progressed from MCI to dementia. And we know that, let's see, the last point here on this slide is that the annual rate of conversion from MCI to dementia, so these are people who are moving kind of down this curve, is about 5 to 15% per individual. So let's talk a little bit more about what we call normal cognitive aging or senior moments. So just by show of hands, how many people have like misplaced their glasses somewhere in their house and not been able to find them? Yeah, same. Or if you know, run into someone at a grocery store and you have seen them before and you know their name, but you just can't think of it. It doesn't come to mind off the top of your head. Anyone? Yeah, a lot of us. So a lot of these kinds of experiences are what we would call senior moments and can definitely just be a normal part of aging. And I think this is something that you know, many people are concerned by if they start having these lapses in memory or they feel more frequent than they used to be. They can definitely be concerning. It doesn't necessarily mean, you know, your prognosis is ultimately dementia or you have a diagnosis of Alzheimer's disease, but if they're frequent and if they're bothering you, they might be a reason to talk to a neurologist or a psychologist who can do a little bit more detailed testing and help you figure out if you're just having, you know, normal age-related decline or if there's something else going on that we can help treat. And there are a lot of things that can contribute to memory problems, especially later in life, that aren't necessarily neurodegenerative disorders. So these can be, we'll talk a little bit more about medications, prescription or over-the-counter that might have an effect on your memory, things like head trauma, certain psychiatric disorders like anxiety or depression, alcohol, substance use. There's a bunch up here that if you were to come in for an evaluation, you know, we would talk through all of these things and try to tease apart what's going on. And on some level, we can sort of, you know, tell what's concerning and what might be more of a harmless kind of normal senior moment. So a couple of examples, I know the text is kind of small here, but I'll just point out a couple of examples that I think stand out to me are, you know, temporarily misplacing your keys or your glasses in your house. Well, that's a pretty normal thing that happens to everyone, and it might happen to you more when you get older. But something like misplacing items or putting them in unusual places. So putting your glasses in the refrigerator, for instance. You know, that's something that certainly would be more concerning. Another good example I think that comes up here is, you know, sometimes you might have a hard time thinking of the right word that you want to say. That can usually be pretty normal, but if you're forgetting really simple words that you use all the time, or if you're substituting words and saying sentences that they come out and they don't make sense to the people who are listening to you, that's something that would be more concerning. But again, these are all the kinds of things that, you know, you would talk about with your primary care doctor or neurologist if you were to come in for an evaluation. And so next I want to really quickly go through some of the research that we're excited about in this field before we really get down to why we're all here, which is what you can actually do to prevent cognitive decline. So as Dr. Gale mentioned, we know that right now we don't have any drug treatments, disease-modifying therapies for a disease like Alzheimer's, but we do know that there are certain lifestyle-related modifiable risk factors. And so if you look at large populations over many, many, many years, you can, you know, get a sense of what their lifestyle looks like and what happens to each individual in the study. And what we know from looking at tons and tons and tons of people is that things like smoking, physical inactivity, and depression are very highly correlated with risk for Alzheimer's disease, which means that people who do these things more, people who smoke a lot, people who are physically inactive, people who have experienced depression or loneliness, are more likely to develop dementia or Alzheimer's disease. And so we'll talk kind of through all of these things and how to address them, but a couple that I think are particularly important in the research, physical inactivity, especially because it is not just an independent risk factor, but it's also associated with other things like depression, obesity, other cardiovascular risk factors. So it's kind of, being physically active, you're, giving the brain kind of multiple hits. And depression ties into that. We know that that's a huge contributor to AD cases in the US and also worldwide. And then also, we know that low education, which is something that for the most part you can't control as much in mid to late life, but is more of an early life risk factor, was important in this particular study in the worldwide population, but was a relatively small contributor in the US population. And so, excuse me, from all of this research, figuring out what these risk factors actually are, the next phase of research is trying to actually prevent them. So if you are to modify someone's activity or modify their diet or have them be more socially or cognitively active in midlife, does that same person actually experience less cognitive decline later in life? And so there's a bunch of kind of ongoing and interesting studies. I think the big one that made big waves in our field was in at-risk individuals, this top study. This was the FINGER study, the Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability. So it's kind of a mouthful. But basically what they did is they took people who were at risk and elderly, and at risk was, they had a number of different risk factors like physical inactivity, family history, a lot of things, and basically put them through this 2-year intervention where they had nutritional counseling, they had personal trainers to help with their exercise, they did cognitive training, and they had people who helped them manage things like diabetes or overweight and obesity. And these people improved or maintained their cognitive function. Even though they were at high risk for developing Alzheimer's disease, they maintained their cognitive function or improved relative to a group that didn't get this intervention. And so this was really exciting for us because it was kind of the first time that we, saw in a big population that by actually changing these things, you could impact the course of the disease. There have been similar studies in patients who have subjective cognitive decline. So the MAPT, I won't go through the details, it's like a very similar protocol to FINGER, and then also in patients who already have mild cognitive impairment. So if you take patients who already have cognitive impairment and put them through, all of these different activities, can you actually slow down the rate of decline?
And what was the result?
So all of these studies showed an impact on cognition in all of these different groups, and
were these all different hospitals, or?
Yeah.
And like how many people would make a study?
Yeah, so different, these were all kind of different sizes. The FINGER study was thousands, and that's why it was particularly exciting, because it was a huge study. The MAPT, I don't remember the exact number, it was definitely smaller. I don't know if you remember. The Thinking Fit was a pilot study, so this was only a handful of individuals, like 40 to 50 individuals. But just to give you a little bit of a sense of what a study like this might look like, so we run kind of similar studies, and we think about similar studies in our clinic as well. And so this is just a schematic from the Thinking Fit study, and what this shows is that for every participant, they went through a control period where they just reported their activities. They did no activity modification, just went about their day-to-day lives. And then in the next phase of the study, they did this activity intervention where they had individual cognitive therapy, group cognitive therapy, and physical activity. This was like a coached workout session with a personal trainer. And then they ended the trial. And so they showed positive results on cognition in this small group and plan to scale up the results of this study. And so based on the FINGER study, a ton of research money is going into replicating studies like this in very large samples. And so the biggest kind of upcoming or planned study is of 2,500 individuals across the US. And it's using a very similar protocol to the FINGER study. And so that includes physical exercise, nutritional counseling and modification, cognitive and social stimulation. So this is guided with a teacher or with a computer program. and then extra support for helping people manage other medical conditions that they have. And they're going to look at changes in different aspects of cognitive functioning and memory. And this is all going to be primarily funded through the Alzheimer's Association. It's a $20 million study. So this will be something to keep an eye on. Certainly will be interesting. So just to kind of briefly summarize about the research, we could talk, there's a lot of studies in this field, but I think the important take-home point for me, and when I talk to patients who come into our clinic, is that what we have really found is that it's multimodal studies that show the greatest effect. And so this means that there's a lot of studies that only study physical activity, only study diet, etc. But the studies that we are particularly excited about are the studies where they put patients through these protocols where they do kind of a little bit of everything. And I think that really informs how we think about what we recommend to our patients, because we think that, we're going to give you a lot of different recommendations and you don't have to do them all, but we think that doing a little bit of exercise, changing your diet a little bit, maybe being a little bit more socially and cognitively engaged, all of those together are going to be better than just doing a lot of one thing. And so these are just two studies that, kind of give the same take-home point that I just said. This graph on the left, we can see, so this was a study that looked at physical activity and diet. And the line in black on the top, this is people who were, this is a little confusing, so this was the probability of remaining AD free. So these are people who did not get Alzheimer's disease. And so what you can see from this graph is that, over 12 years, the people who had high physical activity and really good diet were the group that remained Alzheimer's free for the longest. And similar here, this was just a different study that looked at mental and physical and social activity. And we saw that in this study, the people who had high levels of both cognitive activity and physical activity did the best out of the entire group. Great. So now what we've all been waiting for, which is what does this research actually tell us, and what does it mean for what you can do in your day-to-day life? So I'll go through some recommendations for diet and exercise, as well as social and cognitive activity, and then I will give the mic back to Dr. Gale to talk about cognitive reserve, sleep, stress, medications, and supplements. So first, just to get started, this is something we think a lot about when we talk to patients about this, because everyone kind of knows or has a sense of, what's good for you. And a lot of that comes from what's good for your heart, what's going to keep your heart healthy. And the great thing, I think, about brain health is that we know that brain health and heart health are linked, that anything you do that's healthy for your heart is also going to be healthy for your brain, and a lot of the things that you can do to take care of your brain are also going to take care of your heart. And so I think that you will probably not be surprised by many of these recommendations, because they're probably things you've heard with regards to heart health before. And so just to give an overview of kind of what we'll go through and what's the most evidence-based, so we really think of all of the things that we recommend and all of the things that you could possibly do to help both your heart and your brain. The things that have the strongest evidence are physical activity, diet and nutrition, and we'll talk a little bit more about specific diets, and then social and cognitive activity, and those two things really go hand in hand. We'll also touch briefly on sleep hygiene and stress management, managing your medications, and taking care of your overall health and well-being. And as I said before, we know that there's significant evidence that doing these kinds of things can both decrease the chance of developing dementia, but also if you already are experiencing some kind of issues with your cognition, that it can kind of slow or boost up the shape of that curve and help you kind of stay where you are and stay stable. And we also know that doing a set of these things is more effective in slowing the rate of cognitive decline than doing just one thing. So to start out with physical activity, we know that in terms of both preventing and also slowing the rate of decline, we know that cardiovascular activity specifically is the most strongly associated with lowering your risk of both developing cognitive impairment and also progressing in cognitive impairment. We know even in healthy people, regular cardiovascular activity helps improve things like their global cognition, executive function, and attention. So these are patients both who are healthy and at risk, and also patients who already have cognitive impairment. There's a bunch of different studies that study kind of different, how many times per week and how often and how long the sessions are. I think the general consensus that we like to recommend is 30 to 40 minutes, 3 to 4 times per week. And that is what we would consider to be like moderate cardiovascular activity. The cardiovascular component is super important. So I put below here, this is from the American Heart Association, looking at your target heart rate. So, this is not full out, sprinting exertion. We want you to be kind of in this moderate middle group here. So not getting to your highest maximum heart rate, but just boosting your heart rate up and sustaining it over a long period of time. And we know that this is particularly important, we think, because aerobic cardiovascular exercise increases the flow of blood and the flow of oxygen to your brain, and helps keep your neurons and other parts of your brain kind of healthy and help them live a little bit longer and grow a little bit more. And so again, I told you that the goal is to have moderate activity level consistently over about 30 to 40 minutes, and there's a bunch of things that you can do to achieve this. So I think the most obvious one that most people will be able to do, it looks like many people in this room will be able to do, is walking. So that can be on the treadmill or walking outside. But we also think that bicycling, stationary bicycling, any kind of group activity where you're getting your heart rate up a little bit, like a group fitness class, swimming, water aerobics. There's a lot of different options here, and many of which are low impact and people can sustain until very late into their lives. And so overall, the goal of cardiovascular activity is to increase your heart rate, and you can do that. You can feel your pulse here, you can feel it on your wrist. You can also look for feeling a little bit out of breath, not too out of breath that you can't have a conversation in short sentences, but if you're walking with a friend and you can kind of drone on and on and on like I'm doing right now, then you're not exercising quite hard enough. You can also think about if you're sweating lightly, but not drenched, that's kind of right where you want to be. And the last point on the slide I think is also super important. So cardiovascular activity is not, strength training often doesn't really fall under that umbrella, but we still want you to continue to do that. It's super important for preventing falls and preventing injury and making sure you can continue to do the cardiovascular exercise for as long as possible. So in terms of diet, I'll go through some specifics here, but the kind of things to keep an eye out for are the Mediterranean or the MIND style diet. So this is overall an anti-inflammatory diet that we know is associated with a lower risk. Okay, we good?
That's the best part.
Okay, great. And we're done. No, is associated with a lower risk of developing Alzheimer's and also of continuing to decline on that cognitive decline curve. So just briefly to go through this, but I'll throw some more specific recommendations up here as well. The kind of things to think about in the Mediterranean style diet are every day having some fresh fruits and vegetables, and specifically greens. Getting most of your protein from what we call legumes broadly, but which includes beans, chickpeas, lentils, and nuts. And fish, basically any kind of fish. We know have omega-3 fatty acids, which are healthy for the brain and healthy for the heart. Getting most of your carbohydrates from whole grains, so that's like whole grain bread, brown rice, some of the ancient grains like quinoa or farro. And then using olive oil as opposed to, a canola oil or butter or something for cooking. And then in moderation, we think things like poultry, eggs, dairy, and the Mediterranean diet also includes wine, up to 1 glass per day is fine. And then things to avoid would be sweets with refined sugars, red meat, and saturated fats like butter. So just to go through a little bit more of what this might look like. So I mentioned whole grains, and some examples would be, like I said, whole grain bread or brown rice. There's also great whole grain pastas these days. So basically, if you think that every time you're going to eat, something that's carb heavy, like white bread or white rice. You know, it's totally fine. We really strongly encourage you to have carbohydrates in this diet. It's not a low carb diet by any means, but as long as they're whole grains that your body can process slowly and derive a lot of nutrients from. So this is a good, I think this is a good picture because this shows what you're getting in whole grain is the whole grain. And when you eat any of these white products, they're really stripping away most of what has any nutritional value. I talked about green leafy vegetables. This can be literally anything. We just would say stay away from iceberg. I mean, you can eat it, it just won't really give you any nutrients because it's water. And then other vegetables, we recommend at least 1 serving per day, and this can be really anything. There's nothing you want to specifically try to eat more of or stay away from. It's really more about including a diversity of vegetables and of fruits as well to kind of get the broad spectrum of phytonutrients. Yes, thank you. Good point. So in terms of these actual specific recommendations, we will share this with the senior center here, and so you'll be able to get a copy of this as well. So don't worry about writing anything down or, you know, it's a lot of specifics. I talked about extra virgin olive oil, about 1 serving per day. So if you think about incorporating that in your salad dressing or just in your cooking or, you know, wherever, there's a lot of ways to do this. We think nuts as well are really high in kind of the healthy unsaturated fats. And we say 5 servings per week, or basically a serving every day, and that's like about a handful. It's not a ton, but a little bit every day is great. I talked some about fruits. I think berries specifically, and specifically blueberries of all things, have kind of the strongest evidence base, but really getting a diverse set of fruits and berries. And then beans and legumes, this can be anything. This can be hummus, tofu, any soy products. These are like kidney beans, I think. You know, any bean that would come in a can is great. We, in the Mediterranean diet, we kind of recommend getting most of your protein from fish or chicken, and especially thinking about incorporating some of the fattier fishes that are a little higher in those omega-3s, and those are salmon and tuna. And mackerel, which is not up here, but is another one you can think about. But really any kind of seafood, even like shrimp, scallops, lobster, is going to have many of these kind of good heart and brain healthy compounds. And then I already told you things to avoid: red meat, processed meat, so this is like lunch counter meat or sausage or pepperoni, butter, pastries and other desserts, fried food, refined sugar. And people, I always get this question, so I'll just answer it now. People always ask me about sugar substitutes, like Splenda or whatnot, and we actually think they're probably equally bad, unfortunately. Sorry. And just a little bit about the research behind the diet. So the way that, you know, we sort of come up with these recommendations is we look at these large samples of people who just live in the community, and you track what they eat over years and years and years. So in this study, this was over 2,000 people who started out healthy at year 0, and this is a big study in New York, and they basically saw that over 10 years, people who had high adherence to this diet, the Mediterranean style diet, actually survived for longer and also had lower rates of cognitive decline. So these are the kinds of studies that we would do to kind of test these different aspects of diet. And in terms of different types of diet you might hear about, so I mentioned Mind and Mediterranean style. You also might hear about DASH, which is a very similar type of diet. All of these, if you go back, we'll send this out, but if you go back to that kind of like traffic light thing that I put up at the beginning, all of them fall into that exact same pattern. So if you're following DASH, Mediterranean, Mind, it's all the same and it's all good for you. What these 2 graphs just show is this is a study from 2014 where they did a head-to-head comparison of these 2 of DASH and the Mediterranean style diet, and found that following either was basically equally good in terms of your cognition. And then what researchers have done is kind of combined both the DASH and the Mediterranean into this diet called MIND, which is the Mediterranean DASH Intervention for Neurodegenerative Delay. But I want to just, you know, make sure that you guys kind of know all of these different things that you might, ways that people might refer to these kinds of diets so that if it comes up, you'll know what we're talking about. So I'll go through a few slides on social and cognitive activity before I wrap up here. So we know that keeping the brain active and challenged, we like to think of the brain kind of as a muscle. So, you know, we think use it or lose it a little bit. Like the more that you're keeping it active, the more that you're challenging it, the more it's gonna keep being able to learn new things and be adaptable and remember the things you need to remember, etc. And so we know that social activity and cognitive activity is especially helpful for memory and processing speed. So how fast you can actually think about things and do tasks that need you to do a lot of thinking or organization. We know that things like learning new skills, being active in your community, keeping in touch with friends and family, these are all really good examples that would fall into these categories. And we also know that both mid and late life activity levels are important. So it's not just getting into retirement and saying, okay, great, now I'm gonna challenge my brain all the time. We also know that it's important what you have done in your middle-aged years as well. But that being said, we also know that because your late life activity is still important, it's never too late to start or kind of bump up your activity levels in any of these categories. So just some examples I put up here. You can, any of these things you can do alone at home or out in the community. So things like puzzles and games, reading, kind of taking in new information, challenging yourself in that way. Learning, I talked about learning new skills. Socializing, whether it's by phone or in person or having people over to your home, whatever it may be. And then, of course, activities out in the community, and these are great. Something like coming to a talk like this, because you're both, you're taking in information, you might be learning something new, but you have the opportunity to interact socially with all these people around you. So you're really getting a little bit of both here. And just a little bit about the research here. So in terms of social activity, we know that people who have smaller social networks, who interact with fewer people on a day-to-day basis, are more likely to experience cognitive decline. And so we, on the flip side of that, we know that people who have daily contact with friends and family, whether it's by phone or in person or however you communicate, people who have that daily contact cut their risk of dementia in this study in half. So this is a hugely important part, we know, of cognitive decline and cognitive aging. We also know this kind of second study that's mentioned here talks a little bit about depression, which I mentioned earlier. So we know that people who are lonely and who have smaller social networks have faster cognitive decline. And that is not just being lonely or having a small group of people you talk to, but actually having active depression or a diagnosis of depression on top of that actually makes cognitive decline even faster. And so when we talk about social and cognitive activity, we're really trying to think about broadening your social network, making sure you're doing things that are fulfilling. And the good news here is that there's a ton of different things that can fall into this category. And I think that's it for me. Yeah. So I'm going to turn it back over to Dr. Gale, who will talk about the rest of these things that I've listed, and then we'll take some questions from you.
Thank you. How's everybody doing?
Good.
Good. We're giving you the social and cognitive simulation today, I hope. We will have more to come, and then we'll take some questions. Okay, so 3 last topics. So cognitive reserve. So this is an important topic. So what cognitive reserve is it's the resilience of the brain to function at the highest level that it can, and to resist the changes that happen with normal aging or that happen with disease, like Alzheimer's. So that's the concept. There are multiple factors that contribute to cognitive reserve. That is, let's think about it as the strength of your brain. Some of them are things we can do something about, and some of them we can't. For example, people are endowed with different levels of intellectual ability, which they can build on, okay? But that, for better or for worse, and controversially or not controversially, that goes into cognitive reserve, okay? The degree of childhood education that one gets, so if you think about the public health implications of this, and globally, is also a factor that builds the strength of the brain, but with limited formal education, it is an increased risk factor for later life cognitive decline. So you can imagine that that's a very complicated social and global issue to consider. Other aspects of cognitive reserve include things like the degree of brain injury that someone has had, say 1 or 2 concussions, or 3 or 4 concussions that someone had playing sports when they were young, versus dozens and hundreds of subconcussive or concussive injuries, like with football players and that kind of thing. So the degree of controlling one's own health problems. So someone who has high blood pressure for 30 or 40 years and doesn't control it, or doesn't seek ways to control it, is at more risk for lower cognitive reserve and thus dementia. So what this graph is showing is that this graph is actually showing that the degree of plaques in the brain that are the hallmark for Alzheimer's disease, which you can identify these days using particular imaging scans of the brain, like PET scans. If you take a group of people with the highest cognitive activity at any age, they have the lowest degree of evidence of early changes of Alzheimer's disease or plaques in the brain. Okay, we can come back to that more, but there's evidence to show that there's biological changes that are reduced or mitigated by doing these brain healthy activities, which social stimulation is another example of cognitive reserve. So on the topic of building a resilient brain, the optimal thing is to have lifelong mental stimulation. Okay, so again, this is the curve that we introduced at the beginning. So on the x-axis is age, and on the y-axis is cognitive function. So the purple curve is the average population that has normal changes with aging is the purple curve. For people who may have early Alzheimer's disease or are going to get Alzheimer's disease that we don't know about, the higher their resilience in the brain, the less severe the cognitive function is at that age. Does that make sense? So for whatever factors go into building a healthy brain makes a difference if that individual is susceptible or vulnerable to get Alzheimer's disease. Their symptoms will either be a later onset or will be less severe than their peer who doesn't have a resilient brain. This schematic on the right is showing some of the things a couple of things I didn't mention about building cognitive reserve. So social support, which Hope touched on. So people with, if you have more of a social network, which is just defined as the number of people that you engage with on a daily or weekly basis through midlife on, let's say, have more of a cognitive reserve. The brain has more connections, more synapses, more plasticity in those cases. And I mentioned education. And positive affect is an interesting topic. People who think positively or who manage stress or manage periods of depression in whatever way that they do, through the health system, through doctors, through their own activities, etc., have a stronger brain and are more resilient when there's cognitive decline. Okay, 2 more topics, sleep and stress. So first, sleep. So sleep is extremely important for the brain, as we know. So there's things that happen overnight in the brain, we know from animal studies and from human studies, that are in charge of consolidating memories that occurred during the day. So people with disrupted sleep have a disrupted mechanism of really what we call consolidation, or inserting information or memory in the brain to hold for longer periods of time. And there have been a number of studies to show that people who have disrupted sleep, significant disrupted sleep, or who have sleep disorders like, say, obstructive sleep apnea that is not treated, that is not addressed, have have an increased risk of having plaques in the brain. So again, going to the most common type of dementia, which is Alzheimer's disease, there's evidence that suboptimal sleep is itself a risk factor, an independent risk factor for the development of early changes of Alzheimer's disease. So what this schematic is showing is that it's kind of like a negative catch-22 cycle of people with like poor quality of sleep, have an increased activity in the brain, neuronal activity, which leads to breakdown of cells, which leads to accumulation of the bad actors in the brain, which are these plaques and tangles that make up the disease that we call Alzheimer's disease are basically accumulation of the breakdown of cell products that are not being taken out appropriately in the normal brain function. So sleep is an important function, is a evolutionarily required and necessary brain function that helps us actually to kind of take out the trash at night in the brain, and also to lay down the tracks of memory that we form during the day. So that's essentially what this is showing. So the practical aspects of that are, who's ever heard of the term sleep hygiene before? A couple. There's a term we used that is called sleep hygiene, which is essentially good sleep behavior. So doing things for you, whatever that is for you, and it's different for everyone, that puts you in a state in the evenings to get ready for bed, to decompress, and then to go to sleep and have the best chance of having a restful night. So those include things like being physically active during the day. We know that the more people are physically active in general, of all ages, the more tired they are and the more restorative sleep is. Keeping your bedroom quiet, dark, and relaxing at night, removing electronic devices. If you're feel like you're not getting restful sleep, but your behavior includes, looking at a bright screen on the iPad and reading before you go to bed, or watching movies late into the night, then you're not setting the brain up, I guess, for the natural processes that it would go through to give yourself restful sleep. And then some of the obvious things like avoiding large meals at night, avoiding caffeine and alcohol before bedtime. So in the top I put in, which was kind of an interesting comment about what the CDC, what the Centers for Disease Control says about optimal sleep per age. So from age 18 to 60, evidence shows that you need 7 hours of sleep per night, let's say. In age 60 to 64, it's 7 to 9 hours, so a little bit more. And then age 65 and up is 7 to 8 hours. So everyone is in the range of 7 to 8, 7 to 9 or so, let's say. But that's something to think about. You also have to couple this with what we know with aging is that people actually tend to sleep less. Who thinks this decade they're sleeping less hours than they were in previous decades? Show of hands. That's a very common experience and phenomenon, despite the recommendations that many people, not everyone, age 60s, 70s, and 80s generally sleep less. They tend to wake up earlier, etc. So there's nothing wrong with that. That's a normal, function. But you have to do what you can to try to get optimal sleep for age. I see hands. Go ahead.
What about bathroom calls? Is that
Yes, that's a great question. That's a great question. The plague of all of us when we get older in particular. So if you're falling back to sleep reasonably well, even if you're getting up a couple times, I think you can throw that into the category of restorative sleep. It's not optimal. The optimal thing would be to stay sleeping. You can reduce that by the obvious things like not drinking liquids late at night, etc. But I don't know if I have a great answer. I mean, I think the problem that I've seen with patients is if something is on someone's mind, they feel particularly stressed or anxious, they're more likely to not be able to fall back asleep when they get up for a bathroom break. So we'll come back. Let me finish. Yeah, please. Sure.
Because I've spoken to a number of people, and they seem to think 2, maybe 3 times is not excessive once you get into your 80s or so, as you get I don't know. In fact, when we were talking about much of this, we looked at 50s, 60s, and 70s.
Yeah, yeah,
What happens when we get into our 80s
Sure.
or 90s?
yeah.
Can we do the same thing that we're discussing as far as health issues and amount of sleep and that sort of thing?
Sure. So when you mentioned that, I'm trying to think about studies and the science to give you a real evidence-supported answer.
Yeah.
I mean, these large population studies typically include age 55 to 85. That's a typical higher end cutoff. For some of our like drug research studies, they go to 90, but usually it's 85. So I think that this data generally applies, assuming that the distribution of age range is fairly equivalent, which is usually a target, applies up through mid-80s, you know. But you're right. I mean, we talk about this all the time in our work. The brain health recommendation for someone who's 65 versus 85 is just inherently different in mobility, in various factors. I will say that maintaining one's overall health, emotional health as well as physical health is extremely important at all ages. So someone with sugar imbalance or uncontrolled sugars, pre-diabetes or diabetes, or someone with blood pressure that is uncontrolled at any age through 80 to 85 is itself a risk factor even at that age for decline, for example.
I take melatonin to help me relax in the evening.
Sure,
I
yeah.
assume that's not an issue or a problem.
It's fine. That's on my last slide.
Oh, okay.
I'll get there in a second. I'll be there 2 seconds, I promise. We will get to everybody. Okay, so just a quick thing about stress. So basically, there is biological, scientific evidence that the experience of stress is itself a risk factor for poor brain functioning. And in particular, you can demonstrate this on cognitive testing. If someone has detailed pencil paper testing in situations of stress, what we think about is their cognitive or mental function is declined compared to not. So this just makes the point that there's a stress response in the body that's a physiological stress response that happens that impairs the brain function, cognitive behavioral functioning. So just to plug in for a couple of things, there's a general practice of awareness that there's a buzzword of mindfulness that many people have heard about. I say buzzword only because there are truly genuine practices of mindfulness, and then there are TV commercials of how to be mindful. I encourage you to think about and look into what this term means, the practice of mindfulness. It can be very life-changing for people. It's just a simple awareness of the body, awareness of thoughts, watching one's thoughts, and emotions enter the brain and seeing them as thoughts, and that you may not be the author of those thoughts, but they kind of arise in consciousness and then go away. That kind of strategy, which is a cousin to meditation or Eastern-based practices, is very helpful and interesting to look at. Tai Chi is listed here, and general breathing exercises and ways of physical relaxation. These are things that we all know about, but hearing about it and seeing it in the context of memory and thinking difficulties and neurology, I hope will be helpful. And then finally, finally medications and supplements and their relationship with brain health in general. So there's a lot to talk about. This could be 2 whole lectures to discuss because there's a huge industry, as you know, promoting supplements for brain health, like out there. The recent one is this Prevagen, which is the jellyfish extract, where you can take some. What this highlights, actually the next slide does, I'll get to that in a second. So over-the-counter medications like Benadryl, which is Tylenol PM, and a couple other formulations are not great for the brain. Okay, they're on an occasional basis, sure, but it's important generally to run by your primary care doctor or read a little bit more about supplements that you're taking in general to see how they're impacting the brain. For example, Benadryl or diphenhydramine, it has some anti-cognitive effects. The reason why it helps people relax and or sleep is because it's kind of shutting the brain down in a way that is not as beneficial as something like melatonin, which the gentleman over here mentioned. So melatonin is generally thought to be a safe, natural supplement. The brain produces melatonin on its own. It's the hormone that allows the brain to get into sleep mode. Melatonin is an example of a supplement that could be brain-friendly and beneficial. There are medications that you might get for various conditions that have some anti-memory or anti-cognitive effects. These are things, again, to talk with your primary care doctor and say, hey, can we spend a minute just to go over the medications I'm taking to make sure that there's nothing that's there that, especially for people in their 60s, 70s, and 80s, can be particularly detrimental to cognition. I put in, not to call these medications out, but I will for a couple of them. There are bladder medications like oxybutynin, which is Detrol, for example, which is not a great medication for the brain. You know, there are alternatives, for example. There are reflux medications, and there are particular blood pressure medications. You have to make an individual decision with the docs that you talk to decide for you, but this is sometimes even well-intentioned providers are not thinking as much about cognition and memory and aging when they think about medications. So it's something to consider. And then I put in smoking, for example, we know for various reasons is not, is not healthy. This should be an obvious point, but in brain health, it's the same. It's the case. Marijuana or THC, cannabis, cannabidiol oils, all of that is very difficult and controversial to draw conclusions about, because there's a lot of research going on in the benefits of cannabis for Alzheimer's disease in particular, and also occasional lifelong use of cannabis doesn't seem to be detrimental, harmful to the brain. Daily chronic use of cannabis over many years definitely has cognitive side effects, which has been demonstrated in many studies when you just do normal cognitive testing for someone who reports 20, 30 years of frequent cannabis use, et cetera, et cetera. So that's a whole kind of long, interesting discussion, but what's an interesting part of that is that cannabis is being used in various formulations in a lot of neurological conditions, like multiple sclerosis is a good example, Alzheimer's disease, et cetera. So stay tuned for the story about cannabis. In Massachusetts, we have open arms for cannabis in multiple ways, so we will be embracing that. Okay, and then lastly, I'll just highlight, let me say one thing about this. Vitamin E is really the only supplement that has enough evidence from studies that has benefit for the brain, and in some studies in Alzheimer's disease has shown some change of people's a benefit of people's daily functioning over time. It's not major, but it's enough that we have these conversations with patients with Alzheimer's disease in our clinic that it's pretty reasonable to be on vitamin E supplement. Okay.
How much?
So, a thousand international units or milligrams, but IU is typically the dose twice a day. So there's a couple of studies that have shown that there's some hint of benefit for functional decline, for daily functioning decline with vitamin E. I mentioned that to contrast with a lot of other supplements like ginseng or ginkgo or a lot of different things. If you read online, you will read about coconut oil is another good example. All of these may have an individual benefit and are probably safe for you or for me or for someone else. But as far as the studies have shown, when you look at 1,000 people to try to prove that something like coconut oil, tea teaspoons a day can make a difference with the decline for Alzheimer's disease, there's no evidence that that's the case. Okay, does that make sense? So I've, in an individual basis, if you, I've had many patients who, let's say a handful of patients who've done a concerted trial of something like ginkgo as a supplement, and they have experienced what they perceive as memory boost and less decline. I think as a doctor, hearing that, I'm okay with the safety, I'm totally fine with that. Same thing with ginseng, same thing with coconut oil, same thing with Prevagen, this medication, this supplement I mentioned that's an extract of jellyfish. But I can tell you from the scientific standpoint, when these things have been studied in the way that aspirin has been studied, or the kind of typical randomized controlled trials, the only thing that really has kind of a hint of a benefit is vitamin D supplements, basically. To this point, at this point in time. That could change next year, that could change the year after, but that's where the science is right now.
And it's B12 though, specifically, right?
So this B is actually talking about like B12, but also B6 and B1, thiamine and riboflavin as well. Riboflavin is B2. It's B6. It's pyridoxine. Anyway, B1, B6, and B12. But you're right. I provide B12 here because B12 is a common test that would be done in a primary care office or in a neurology office to look for deficiency. If someone is low vitamin B12, it should be replaced with vitamin B supplements or with injections, but there's no evidence that superdosing on vitamin B, if your levels are normal, there's no evidence that taking more vitamin B above your normal blood levels is going to do something for your risk of declining. Does that make sense? It can worsen your normal decline or your decline with existing Alzheimer's if it's low, but there's no evidence of super supplementing above it. Can I finish last one? And then we'll okay, just because I want to, okay. So, last slide. High blood pressure, high cholesterol, diabetes, the metabolic syndrome, which includes being overweight, in particular at the waist, and depression, are each important health issues that are particularly important for the brain that should be considered, addressed, talked about with doctors, and done. Everything should be done to try to reduce their morbidity. Okay. Thank you. So we'll take some questions.
Yeah. Can I back up again to this Prevagen? If you turn the TV on any evening, you
Right.
average maybe 4 or
Yeah.
5 programs that use that advertising.
Yeah.
And again, they press the idea that it's brain health. But when I call my physician to find out if it's adequate or should I be taking